Welcome back to NeuraXis Care and Research Center. Let's continue third part with Dr. Albert Fenoy.
Not to dwell on that. We then looked at the probabilistic chartography based on these patients, and we could see that when we turn on the stimulation on the right and on the left, we see that there's clear, as expected, orbital frontal activation as well as prefrontal cortex. But again, if we're assuming that the orbital frontal cortex is the modulator of antidepressant effect, we have clear connectivity to it. So at 5 years, for the patients, only four of the patients out of our series achieved 5 years by the time of the publication, at the time of this graph. And 4 of the 5 patients that achieved this time point were responders. And so that's pretty highly significant. So patients who were responders at 1 year continue to be responders at 5 years. So this is a durable treatment, which is important to show. And other depression targets also show a very similar type of effect. There are some patients that did not continue for various reasons. Some patients that wanted to have it removed due to a variety of other issues that developed. Some patients who were not responders initially became responders later on. There's multiple effects or reasons for that, but the point of this graph chart is to show that patients have a response and it is sustained, and that's a key thing. So this last year, this point shows what's happened with all of our patients. One patient dropped out, then one patient was a non-responder, withdrew ultimately at 3.5 years. These are the patients who are not at 5 years yet, and one non-responder. There are some non-responders that just never improved. But again, 6 out of 9 patients were responders. So we started a new protocol after our 10th patient to increase the sham stimulation phase to 3 months. And so one of the beliefs is that by inserting the electrode, just like when we insert the thalamus, there's a release of adenosine, which we think is one of the mediators why a patient has a tremor release right away. We don't know exactly what the mediator is in this disease, but it's certainly something that lasts longer than 4 weeks. So it's believed by consensus around the world that 3 to 4 months is considered a good sham stimulation phase to kind of wash away the insertional effect. And so that's why we increased our sham stimulation phase to 12 weeks. We also changed, we had inpatient, in-person assessments for the first year for every week, and we changed our protocol so that it would, at 6 months, patients did not have to see us every week in person. They could visit us by Zoom, because some of them did not want to live in Houston anymore, wanted to go back to where they live. That was that. So this is a current status of 12 patients who actually completed the first full year, and this is basically the same graph that I showed you earlier with the addition of 2 other patients that started their stimulation at week 12, and those are in yellow here, and both those patients are responders as well, so our response rate is definitely increasing with time. This is now 73% response rate, 8 out of 11 patients that completed the 52-week protocol. Since this chart has been finished, we've had 4 other implants since last October, and not all of them have completed, obviously, their 52 weeks since the patient 13 was implanted on October 28th. But the 3 people that have been turned on are all responders, so that's even better. So we're having a very large response rate, so it's probably over 80% now, which is fairly significant. So this is you would think that it's kind of crazy. We've only implanted 16 patients in 8 years, but in the United States, it's very difficult to do the surgery. There's a lot of different regulations that you guys do not have here. And so you have to have an FDA-approved clinical trial, you have to have an IRB, you have to have someone to pay for this surgery. So in the United States, if you have an FDA-approved clinical trial, you could have insurance pay for it, but insurance doesn't have to pay for it. And so sometimes you have to appeal for multiple months to the insurance organizations, and they do ultimately acquiesce. The more papers that I've written, the more reason, substance that I show that, hey, this is something that can help you. But if it were something that were available widely to the public and it would covered by insurance, then more patients would probably be willing to have this. But it is recruitment is difficult due to insurance, I'd say, or any other thing compared to diseases where it's not having a problem. I also want to talk about how deep brain stimulation in the medial forebrain bundle is really efficacious for OCD. Now, I don't have a large series in this, but I'm going to talk to one of my cohort friends in Germany. They do have about 9 patients they published just earlier this year, where DBS for OCD, targeting the same target that we use for depression, was very effective. So just like in treatment-resistant depression, when you use OCD patients, we have patients that have very high YLOC scores, and a response is considered a greater than 35% reduction of YLOCs in our Yale-Brown Assessed Compulsive Scale. And so at 9 patients were enrolled, they followed them for over 2 years, almost 3 years. And at 3 months after stimulation, 3 of these patients were considered responders, and that's seen here on this graph. So on this graph here is the follow-up in months. This is baseline, the YLOC score is very high, and at blue is when stimulation got turned on, and this is now monthly assessments. At 3 months, 3 of the patients were responders, and at 12 months, 7 of the patients were responders. So this is a very clear point that basically, by accessing this reward system in patients in different diseases, patients are improving. We do not have data on addiction, but it's believed that this would also be something that's very helpful, because you're accessing and improving a deficient reward system, increasing pleasure without the need for other reasons to have that pleasure. Same thing with OCD, you're taking away that obsession, decreasing that compulsion by providing the brain with the things that it needs. So it's very it's exciting, interesting. We don't really know how this will go, but it's definitely promising, and it just takes time to accumulate all this data to see how we can use it in the future. So that's pretty much all I have to say. More of what I wanted to be here for was to answer questions for people who might be interested in how they can apply this. So thank you.